Hello, my name is Dr. Scott Lederhouse. What we're going to speak about today is consent issues regarding a herniated lumbar disc with radiating leg pain, so-called lumbar radiculopathy. We will go over some consent issues, and you will be provided with a consent, and this consenting procedure is one that's not meant to take the place of speaking with the physician, however only giving you supplemental information. You will have a consent that will look similar to this, which we will review. This is the lumbar spine viewed from the front. This is the front of the spine here. The numbering system in the lumbar spine is 1, 2, 3, 4, 5 for the lumbar spine. And this area down here is the sacrum. The first part is called S1. The discs can be seen at each level, and normal disc height at each level we can see here. And then there's corresponding nerve roots that come out at each level or hole, or foramen as they're called, that supply sensation, movement, and pain that could occur down one leg or the other. This is the back of the spine here, and these are the spinous processes that we can feel through the skin. The area where the discs are in the interlaminar space, or this is the lamina between the bones, and the disc is approached from a posterior approach in most cases. These are the lower sacral and coccygeal nerve roots that are also present. When there's a disc herniation, that corresponds to the disc pad between the bones, and the herniation occurs when the disc material protrudes back into the spinal canal up against a particular nerve root. The nerve root will be compressed, and wherever that nerve root goes down into the leg will cause corresponding pain, numbness, tingling, and weakness in the distribution of that nerve root. Nerve roots also supply reflexes into the legs, and that's why we test reflexes, because a nerve root may supply a particular reflex, and by figuring out which reflex is involved, the area of sensation that might be diminished, we can oftentimes figure out which nerve root may be involved in the low back. This is a drawing representing the normal sensation pattern that we see in legs. Each area of sensation has a particular nerve root distribution that can be depicted here in this drawing. By the location of loss of sensation, we can oftentimes figure out where the particular nerve involved in sensory loss or pain. In looking at anatomy of the lumbar spine, the things that we look for on this particular side view, this scan will be shown to you later on, but this is a side view of the lumbar spine with the spine coming down like this. This is the front of the spine. This would be actually the back of the spine. This white area in here is the canal where the nerves go up and down within the spine. Between what is designated as between the L2-3 level, there's this whitish colored disc, which is a normal disc. It's white because it has a normal amount of water content in the disc. When you get down lower in the spine, between what's designated as the L4-5 level, the disc is grayish in color, indicating some degree of what's called disc degeneration, which means drying out of the disc. The disc degeneration is a very common problem and entity. It affects virtually everybody. At the 4-5 level, there's a little bit of a disc bulge or protrusion. Some might even call that a small herniation. The terms are used somewhat interchangeably. At the L5-S1 level, there's a fairly large size disc herniation which is present. These are the sort of things that we would look at on a side view of the lumbar spine, and you'll have other MRI scans to look at and compare this with some of the other studies included. These are cross-sectional views of the lumbar spine, looking at the same information, but a cross-section view compared to what we saw in the side view. This is the vertebral body or bone in front. The abdomen would be in here. So this is the bone or disc. This black circle in this area is the sac that contains the nerve roots, which is normal. And here we can see the foramen or exiting nerve roots going through both holes on both sides. That's what's designated as the L5 level. At the L5-S1 level, there's a lighter gray material here, which is that herniated disc that we saw in the last side view image. Now we can see the sac containing the nerve roots has some pressure effect coming across this way here, and in addition, the nerve root that sits in the corner here would be compressed by this disc coming out. So these are the sort of images that we look at and what we're looking at. This is an MRI scan demonstrating a very large disc herniation. It's what's called the L4-5 level. This is a lateral or side view of the lumbar spine. This is a normal cross-sectional view of the lumbar spine demonstrating a very large canal where the nerves pass, and this is normal. This is a very large herniated disc. It can be seen here significantly compressing the nerves going by that location. This can sometimes cause bowel and bladder loss of control. This is another side view MRI scan demonstrating, again, a significant disc herniation at the L4-5 level. The rest of the levels appear to be grossly normal. Occasionally this can cause a paralyzed foot. This is the same patient demonstrating a very large disc herniation occupying much of the spinal canal. Treating someone conservatively with this size disc herniation generally is ineffective. This is another MRI scan demonstrating a large disc herniation at what's called the L5-S1 level. This patient would very unlikely recover without an operation due to the size of the disc herniation. This is a very large disc herniation at the L4-5 level. You can see the significant disc space narrowing. This patient ultimately went on to develop severe back pain at a later time, which required additional surgery. This is that same patient later who went on to develop severe back pain requiring a fusion operation. This MRI scan demonstrates a large disc herniation at the L5-S1 level, as can be seen here with a smaller disc herniation at L4-5 level. The patient had minimal symptoms and decided he would like to be treated conservatively. He underwent a MRI scan approximately a year and a half later without surgery and made a virtual complete recovery in his symptoms. This is the same patient approximately 18 months later without surgery, demonstrating what appears to be complete resolution of the disc herniation. This patient did not require surgery at either level. This is an MRI scan demonstrating severe stenosis of the spinal canal, or narrowing of the spinal canal, combining with a disc protrusion causing severe lumbar stenosis. This can cause radiating leg symptoms down one or both legs and often requires a decompression to relieve the pressure effect at this involved level. This is a drawing representing a disc herniation on the top left view with compression of a nerve root, with the typical symptoms of patient may have tilting the back to the side. The operation involves an opening here which is approximately 4 or 5 times larger than the opening we use, with a small bony opening demonstrating the herniated disc, the nerve root, and the nerve root sac. This is the typical bony opening present, but under microscopic dissection it's a much smaller skin opening than we see here. This is an enlargement of the same drawing previously seen. Again, the skin opening is much smaller than depicted here. There is a small bony window opening, which is approximately the size of the bony window opening that is used. On the left, we can see the herniated disc, followed by the nerve root in the middle, and the sac containing the nerve roots on the far right. The herniated fragment is removed, relieving pressure on the nerve root in this location. This is a herniated piece of disc material. It is a solid cartilage material. It is not a liquid or a gel, as some people might think. This is a typical piece of disc that might be removed in a lumbar discectomy, which would cause significant compression on the exiting and traversing nerve roots. The procedure that we ordinarily will perform for removing a herniated lumbar disc involves making a small incision over the lumbar spine at the appropriate level. Usually the incision lengths are an inch, sometimes a little bit longer, sometimes a little bit shorter, depending on your particular body size. In either case, if we were doing a herniated lumbar disc, for example, at this level, which is between the L4-5 level, we make our small incision, we retract the muscles from the side on the side where you have your leg pain, put a small retractor in that location, and we'll take an x-ray to verify that we're at the appropriate level. Once we've verified we're at the appropriate level, we bring in the operating microscope and everything is well lit and large and big, and we shave off a little bit of bone above the level of the disc and just below the level of the disc to gain access into what's called the spinal canal, which is where the nerve roots exist and pass. Once we've made our boning opening, there's a small ligament underneath here called the ligamentum flavum, which is opened or elevated, and after which we're able to see the sac of nerves go by there called the cauda equina. The particular nerve that may be compressed in this particular level here is ordinarily what's called the L5 nerve root, and under the microscope we're able to see the L5 nerve root. We may touch the nerve root and move it around a little bit, but we retract the sac containing the nerves and the nerve root over towards the center, and then we're looking down inside where the herniated disc exists. Once we've made our bony opening and identified the nerve root and herniated disc, then we'll remove the piece of disc material that's putting pressure on the nerve root, and as well if there are any ligamentous structures or bony encroachment that may be causing some nerve root pressure, we would deal with that at the same time. So we go inside and we take the herniated fragment out, which is putting pressure on the nerve root, but in addition we go inside the disc space to remove additional disc material that will oftentimes be fragmented and as well potentially causing what we call a recurrent disc herniation. This procedure takes on the order of approximately 60 minutes, sometimes a little less, sometimes a little more. We spend a number of minutes just getting x-rays to verify our level, so the actual operating time is relatively short. We'll inject local anesthetic into the skin at the time of the operation to make the postoperative pain less, and oftentimes this procedure can be done as an outpatient. It's not a particularly painful operation. However, we will obviously prescribe pain medicines to go home with, and once patients are up and walking and off any shots for pain and at least able to void once before going home, then they can go home again often the same day. If for some reason there's enough pain that they're not able to go home the same day, an overnight stay in the hospital, and then with the bulk of the patients being discharged on the first postoperative day if an overnight stay is necessary. So that is the basic summary of the procedure that we do for removing a herniated disc. Again, obviously this is just meant to supplement the information that your doctor will give, and you may ask additional questions regarding your particular case, which may vary from case to case. Before you come in for your operation, it will be determined which hospital you'll have your procedure at, and usually a day or two prior to the operation you'll come in and you'll have oftentimes a chest x-ray, electrocardiogram, some blood tests done, and this is in preparation for the operation. So this is usually done a couple of days prior to the operation. Chest x-rays and electrocardiograms can be done in most patients within a month of the operation, but generally the lab tests need to be done within about 3 days of the operation. This says surgical risk complications and indications for lumbar spine surgery informed consent. The first portion is skin and soft tissue infection, and there's a potential risk of infection like any operation. We give antibiotics at the time of surgery and the infection rate is very low. Bleeding is minimum, and we've never had to give a transfusion for an otherwise ordinary lumbar discectomy. Poor healing, keloid formation, that refers to how the skin heals, and we close in what's called a subcuticular manner, which means that the skin and soft tissue is closed with dissolvable suture material. And then on the surface of the skin we'll often use what's called Dermabond, which is a glue material that will help seal the skin even further, which in the postoperative period permits patients to be in and out of the shower more liberally because there is this protective coating. In some instances we may not use the Dermabond if the incision is long or the skin edges need to come together in a particular manner. We may leave actual suture material in the skin, or using what are called steri strips, but for the most part we'll use this Dermabond material. Also describes in the first part stiffness of the back, and that can be from retracting the muscle to the side, and that's anticipated. And sometimes it will present postoperatively as a feeling of swelling in the back, which actually isn't swelling, it's only a muscle contraction. By taking the pain medicines, muscle relaxers, and as well by doing some stretching exercises afterwards, you can help eliminate this cramping and spasming that you may notice in your back. So if you feel a bulge over there, it's not as though there's any disc material coming out or anything like that. It's a matter of just having a muscle cramp spasm in your back. Next section is bone. It says osteomyelitis. Osteomyelitis is an infection of the bone, and we haven't produced that in our practice. We sometimes operate on patients that have infection of the bone, but it would be a very unlikely, rare event that it would cause bone infection. The next portion is a disc space infection we have seen a few of, and fortunately it's a rare complication, but that does produce a lot of back pain. It requires several weeks of intravenous antibiotics. It presents with severe back pain, fevers, and some changes on the x-ray and some blood tests that we can diagnose. But again, this is a very rare event. Progressive degeneration of the spine refers to just age-related changes of the spine that will occur both not only at the operative level but other levels of the lumbar spine. It's a natural aging process, and by doing a discectomy it doesn't eliminate the progression of these changes over time. Progressive subluxation or spinal instability means a slippage of the spine or one vertebra over the other, which is a very, very rare event, and it would be more likely in elderly patients. However, it's an unusual situation anyhow because we're not being involved in the joints of the back, and therefore by just making a small opening in the bone where we remove the disc would be very unlikely to cause any instability issues in the back. And in arthritic bone pain or progressive low back pain. So the surgery to remove a herniated lumbar disc is done primarily to treat the radiating symptoms down the leg. If there's associated back pain, it generally doesn't treat back pain, and in some instances where there is severe back pain, then that is actually treated with a different type of an operation. But in your particular case, we're speaking regarding a herniated disc that is causing radiating leg pain and leg symptoms, and that's what we're treating here. Next section is nerve roots. It says partial or complete injury to one or more of the nerve roots causing weakness, numbness, pain in one or both legs, possible inability to walk, loss of bowel and bladder control, loss of sexual function. That would occur only if all of the nerves at the level that we were operating would be transected or cut across. That hasn't happened. We're operating under the microscope with small instruments, small drills, small bone biting instruments, and so causing that degree of injury hasn't occurred in this practice. However, if there was an earthquake, the lights went out and we had the drill on, then anything is possible. But in the realm of normalcy here, we haven't had these sort of complications. These are theoretical risks that we're speaking about here. Infection leading to meningitis or abscess, again, is a rare event. If there is an infection, that may require an additional operation to drain an abscess and treat with antibiotics. Again, that's a rare event. The development of scar tissue formation around the nerve roots with possible chronic pain in the distribution of that nerve root. Scar tissue forms no matter where we do an operation in or on the body. It will produce scar tissue around the nerve root, which can in some instances cause pain in the distribution of the nerve root, but ordinarily if someone has had just one operation, it doesn't produce significant scar formation around the nerve root that would cause pain in most patients. There would be the rare exception to this. Now, if someone has had multiple operations, then scar tissue plays a more key role in producing long-term chronic pain in the distribution of the nerve root. The next section talks about recurrent disc herniation, possible need for additional surgery. So when we do a what's called a discectomy, we're not taking the entire disc out. We're taking a portion of the disc out. We take the piece of disc that's come out that's putting pressure on the nerve root, and in addition we go inside the disc space to remove any additional fragments that are inside that may come out at a later time. If you can imagine, you take a hammer and you smash something, debris scatters in several directions. The same thing happens when you herniate a disc. The disc material can come out posteriorly or towards the back and produce pressure on a nerve root, which would cause radiating symptoms down one or both legs. There's also torn up disc as a result on the inside of the disc space, and that's what we remove. We remove the additional torn up disc material that hasn't extruded yet. So that lessens the chance of a recurrent disc herniation, but it doesn't make that a 0% risk either. We're probably talking of less than 5, maybe 10% in some individuals. If there is a recurrent disc herniation, then at least at our office we talk about doing a fusion operation as a second operation if that occurs, so that we don't come back multiple times at the same level, producing significant scar tissue formation, which can in some instances get patients into chronic pain problems. But this is not part of that discussion at present, but you may want to ask your doctor about those issues separately. Under nerve roots as well, it says pseudomeningocele or spinal fluid leak in the back or out the wound. As you may or may not know, there's a membrane around the nerves in the back that contains spinal fluid, which looks just like water. In the rare event we get a small hole in that membrane, then under the microscope we close that with a suture material and put a little sealant material over that, and that takes care of that in virtually all the patients. We haven't had anybody coming back with any leakage problems treated that way. Again, it's a rare event that we get any holes in the membrane, but if we do, it hasn't been a consequence later on. General risk, no improvement or worsening of condition, death due to the anesthesia or surgery. Again, if we have a good diagnosis with a single level lumbar disc, we anticipate a good recovery and getting rid of the leg pain. Some individuals may have extensive bone spur formation at multiple levels and may have a normal examination, and in those individuals it becomes more difficult to decide exactly where the problem is coming from. But in a straightforward disc herniation, we anticipate that the radiating symptoms down the leg would be gone afterwards. With respect to death due to the surgery or anesthesia, we haven't lost anybody. There's a potential risk of that, but in our practice that hasn't occurred. Allergic reactions to medications, risk of AIDS and hepatitis from a blood transfusion. We ordinarily will lose maybe 20 or 30 cc's of blood from taking out a regular straightforward lumbar disc, and that would be on a generous amount of blood loss. And a unit of blood is 500 cc, so we haven't had to give anybody a transfusion to do this sort of operation. Many times our blood loss is almost negligible. Maybe a good nosebleed would produce more blood loss than we would see in doing this sort of operation. So it's a minimal blood loss, and we haven't had to give a transfusion. Prolonged hospitalization for some complications of possible long rehabilitation. Again, most patients that are in reasonable medical condition, we would anticipate discharge home the same day of surgery. Some individuals, depending on their pain response, may require a day to be discharged the day following the surgery. However, the bulk of patients for a one-sided, one-level disc removal should be able to go home the same day of the surgery. Older patients may require more prolonged physical therapy and hospital stay due to their general medical health and age. However, this would be the unusual situation for a younger person. Perforation of the abdominal aorta requiring a laparotomy for control of such bleeding. Well, that's an event that hasn't occurred, but it's a theoretical risk, and in front of the vertebral bodies runs the aorta. That's the main artery that comes out of the heart. And if we were going to remove some disc material and went too deep and went through the ligament in front of the bone, then the aorta sits in that location. And if we were to take a bite of the material, it would obviously cause bleeding in the abdomen. It would require an operation from the abdominal cavity to repair that. Again, that's a theoretical risk. And then the last sentence under general risk says the above is not meant to be a complete list of all potential complications of risk, and therefore may not be limited to what has been listed in this outline, such as a urine infection, a pneumonia, some other unrelated event that could occur, but again would be a rare event in the otherwise younger and healthier patients. Next portion says work or activity restrictions. From the time of surgery, no driving for up to 30 days. It's nothing written in stone. Patients need to be off the prescription pain medicine, though, if they're trying to drive, obviously, because you could get into an accident and it's illegal to drive under the influence of drugs. So the first criteria is you'd have to be off those medications. Secondly, it would be a good idea if you were to avoid driving if you notice you had any significant spasms or cramps in your back or in your leg, because you might hit the wrong control. You might try to step on the gas and you'd hit the brake, or vice versa. So if you're not noticing any spasms or cramps down either leg, then, and as well if you're off the pain medicine, you should be safe to drive. So it may be 30 days in one patient, it might only be a week or a few days in another patient. Everybody is individualized, but there's no hard and fast rule on this, but using common sense. No bending, lifting, twisting, no housework, no yard work, limited in issue to walking and resting. Then exercise will be given to you in the post-operative period. So don't try to do too much too soon. The activities that you would need to avoid whether you had an operation or not would be bending at the waist, such as picking something up off the ground. Even picking a piece of paper off the ground, you should stoop with your hips and knees rather than bend at your waist, because bending at the waist produces a lot of pressure on the disc, and if you're going to re-herniate or injure your back, you might do it during that event, particularly if you were lifting up something heavy. So bending at the waist is not a good idea, and avoiding any heavy lifting, obviously. The off-employment could range from 2 weeks to 3 months or more, depending on your job. Some individuals may even be less if they're very motivated to get back. Other patients may take longer, depending on their pain response and what activity they do for their job. If heavy lifting is required for your job, then you will likely have a permanent disability from performing such work. That's relative, and it's obviously up to the patient whether they go back to doing heavy work or not. However, heavy lifting obviously can stress the back, and if you're going to re-injure the back, either a re-herniation of the disc or develop chronic back pain problems, it could occur doing significant heavy lifting in a job after having such an operation. So it's possible that you may have to change what you do or change how you do something as far as your employment. Progressive activity will be directed by your physician in the postoperative period. So most patients will see back at approximately the 2-week mark if we've closed the skin in the manner that I discussed using the Dermabond. We will inspect the wound, see how you're coming along, often provide you exercises to do. It would be the rare case for doing a single level lumbar disc that we might recommend some physical therapy, but if somebody needs to have physical therapy after this time, then it can be initiated. Certain risks must be considered with any surgery. Although every precaution be taken to avoid complications, absolute guarantees cannot be made. Clinical experience and judgment indicate that in general surgical risks are limited. However, surgery remains a human effort. Unforeseen circumstances can complicate any surgical procedure and lead to serious or even life-threatening situations. Although such complications are rare, you and your family should feel free to discuss the question of risk with the physicians. For any uncertainties patients may have, we encourage second opinions from other qualified neurosurgeons. I've discussed the above pertaining to lumbar spine surgery with my doctor. He has explained the procedure and risk, complications, and indications to me in non-medical terms so that I understand them. He has explained my non-surgical options. I've been provided a copy of this form for my later review. Then there'll be a section about what my diagnosis is, and it'll be specific. And then it'll say, I give my consent to have the following procedure or operation performed, and it will define what that operation is. And then you will sign this, and a witness will sign it if there's a witness present, along with dating this document. Any additional questions that you may have, feel free to ask. This is just a consent video. It's not intended to take the place of actually discussing this with your physician. It's only added to give you added additional information that may be time-consuming and cumbersome to produce in each and every patient. So any additional questions that you have, feel free to ask. We're here to inform you. We're not here to try to tell you what to do. That will be ultimately your decision. As far as the outcome in patients, we ordinarily will see a resolution or marked improvement of the radiating leg pain. Tingling usually is gone shortly after the operation. Things that can sometimes linger on for a period of time would be numbness or weakness. If the numbness or weakness is not severe and hasn't been present for too long, we ordinarily will see an improvement of that over time. It would be the rare case where there's been significant weakness or significant numbness that there may be an incomplete recovery of those problems. However, for the most part, the significant radiating pain we would anticipate to improve. Now, if there's been a complicated history, a complicated problem, such as somebody who presents with diabetes, as well as somebody who may have some blood vessel disease into the legs, this can often make the diagnosis more complicated, and as well the recovery or improvement of the symptoms less certain. Because of this, we do extensive testing as we feel needed, whether it's MRI scans or electromyographs, nerve conduction tests, along with our physical examination and assessment, So these are all valuable tools in trying to determine which nerve or nerve roots may be involved in a particular patient. But suffice it to say that some patients are more difficult to determine exactly what is going on, and as a result, we can't always have uniform improvement in pain, numbness, tingling, and weakness due to some complex patients that we may come across. But for the most part, a single level lumbar disc, we can anticipate marked improvement in their symptoms. But we hope that this video has provided you some valuable information as far as trying to make a decision regarding your particular case. Again, this is intended to be supplemental information for you, giving you pictures of MRI scans, some photographs, etc., that can help explain better what it is that you have and may be experiencing, but also to give you an idea regarding what it is that we do for this particular disorder. You may, at the conclusion of this, wish to speak further with myself, Dr. Rodriguez, or Dr. Disney, and in which case feel free to ask any additional questions.